bothered developing a vaccine for them. And to be honest, prior to SARS in 2003, medical virology actually paid very little attention to these endemic coronaviruses. Two of them were only discovered after SARS, and once people started looking at, once people started looking for coronaviruses specifically, but the illness is also too mild and too trivial to warrant, developing a vaccine. The first SARS coronavirus triggered a number of efforts, but because it never made it, it never became a fully human pathogen that with sustained transmission, vaccine efforts and other efforts were abandoned, which I think was a mistake, as we are seeing now. And the other one that is also causing a very dangerous, highly pathogenic human disease, MERS coronavirus, is really still a zoonosis. Sometimes, whenever there are slip-ups in infection prevention and control, causing sustained human-to-human transmission chains, I think most notably in Korea a few years ago, but it can also be brought under control actually quite easily by just applying stringent infection control measures. And the efforts there are now very much directed towards vaccinating the camels, the rich, valuable racing camels and others in the rich countries of the Arab world, which would then prevent the source of human transmission. And I think that is one of the issues. Yes, there have been efforts to develop vaccines against SARS-1, but they were abandoned because once the disease had gone so waned the interest of funders. Also, it's worth remembering that many of the current vaccine candidates are actually based on technologies that are not used for any currently available and used human vaccine. It all sounds great, but ultimately, whenever these innovations come about, they may have all sorts of advantages, but we are not currently using it. So there may be issues that are still to be discovered. That is just a word of caution about it. I'm not a vaccinologist, but my expectations are somewhat tempered. First question is, of course, how protective will the vaccine be? Sterilizing immunity would be the ideal. Whether that will work is a good question. Probably not. So it may give some degree of protection against infection, or maybe even protection against severe disease, which would also be something. So there's a whole spectrum of effects that the vaccine could have. We don't really know where it will land, and I would expect that there will be some vaccines becoming available in the next year or so. There will be not so good ones, but early. And then as time goes by, and if funding can be sustained and interest kept up, then I'm sure we are going to see better vaccines that will take longer to be developed. Another question is, if the natural infection does not induce long-lasting good immunity, what would you expect from a vaccine? And yes, we have vaccines that are actually better than natural infection, human papillomavirus vaccines, for example. So it is possible, but still we don't know how long immunity or protection will last, and whether that may necessitate regular revaccination. So it's we don't know, but that is definitely an option. So it might not be just a question of 1 or 2 doses and you're done for life. Thirdly, there is some evidence from animal coronaviruses. Remember, there are a number of coronaviruses that play a role in domestic animals and companion animals. And like so often, our veterinary colleagues were ahead of us two-legged virologists by knowing about these things and working on them long before they interested us. And there are some evidence of what we call antibody-dependent enhancement, which is a weird phenomenon. It's observed in dengue, both in the wild virus infection with the different dengue virus strains, but it's also worryingly been observed with the Dengvaxia vaccine. And that basically means that by vaccinating somebody, you may actually make subsequent infection with closely related, but not identical viruses worse. And that is something that is at least a theoretical consideration for coronavirus vaccines as well. And then lastly, and it's just blowing up once again for the umpteenth time in America, of course, with certain people wanting to be re-elected, is that there's a long way between developing a vaccine for clinical trial, and I think it's amazing how fast some have made it, conducting these trials, then being licensed, and one can only hope that proper standards will be upheld, and then finally producing hundreds of millions of doses. And you are aware of, obviously, that you know, there are sort of doses have been bought in advance, the risk being that the whole setting up of facilities and so on will be in vain if the vaccine doesn't hold, you know, true to its promise. But you know, that's probably a risk worth taking, but it will still be a challenge to go into large-scale production of a new vaccine in such a short period of time. And looking at things, how things are playing out, I'm actually not so sure that we've learned the lessons of the West African Ebola outbreak, where, you know, people realized, oh gosh, we have had these vaccine candidates in the drawer for a long time, but we stopped funding it because, you know, we had other issues and we wanted to save money and not support this blue sky research, and now we need it urgently. And, you know, we are seeing the same now with the coronavirus vaccines. So there are people who worked on this, and yet it took sort of a new catastrophe to give them the support needed to take it further. Next question was...
Sorry, it's Tamara here. Hi, and hi everyone, and I hope everyone is well. It's strange not to hear anyone or see anyone, but I just wondered, before you move on, whether there are any questions from because...
Oh, sure. Yeah, please ask any.
I think there might be. I think that we might need some discussion, and I think as much as you're explaining this in simple terms, I think there's still quite a lot of technical terms in the mix that are everyday to some and not to all. So I thought we should maybe just check in with everyone, and also just say hi. I haven't, had a chance to greet. So yeah, but thank you so much. Very interesting. And should I check if there are any? Does anyone have any questions or any clarification so far on, or any other thoughts coming to mind about the work that you're doing and questions about this? I mean, we can...
Okay, I'm not sure that I would be able to see any comments or raised hands or whatever, but if you were so kind as to monitor,
I'll keep an eye.
I am too. So,
and just interrupt.
Great.
And if anyone wants to put a question in chat, that's also fine. I'll keep an eye on that.
Exactly. I don't think I see that necessarily, but just interrupt me and ask the question. I think there will be questions that are best answered while we are there, and there may be others that can be kept to the end.
I think your big message is that Trump's not getting his vaccine by October.
So, yeah. I mean, that is, I mean, that thing is, you know, what I worry about. I mean, firstly, I worry about him being re-elected.
Yes.
Secondly, I really worry about this process being so trumped up, to say, but I mean, the Russians and possibly also the Chinese are also doing similar things. This can damage trust in vaccines for a long time. It can do immense damage if people get the impression, whether rightly so or not, that corners are being cut. There is a reason why these processes are in place. I do agree that it's frustrating how long it takes, but you know, there's a reason. It has evolved over decades, and it is there to ensure maximum safety of these measures and efficacy. So you know, one can't just say, well, just rush it. You know, it's not going to work. There are certain things on. So I'm very worried about what it might do, seeing that till today people are falling ill and some are dying due to a very phony article that was published in The Lancet in the late 1990s. You know, I mean, more than 20 years later, there are still hundreds of thousands of kids that have not been vaccinated against measles, mumps, and rubella because of that, and are bearing the consequences. So, the damage can be long-lasting if there's a general loss of trust in the vaccine development process.
And maybe just a question from me, but what are the implications of, a poor vaccine getting distributed and then a better one coming along later on? What happens to the people that got the bad vaccine in the first place? You know what I mean? That kind of idea.
Yeah. I mean, there are two things. I mean, my first concern would be if the vaccine, has harmful side effects. So that would, of course, be very bad. If it's a vaccine that's not as effective as one that comes along later, I think one would consider re-vaccinating people then with a better one. So that, it's actually quite a complicated process, and I think one needs to prioritize certain groups, and healthcare workers, the elderly, people with risk factors would go first. Even if it's a suboptimal vaccine because their risk is so high. And then, when a better vaccine is available, they can be revaccinated. And of course, one will learn. I mean, the other thing is that, the longer something is being used, the more one learns. So, I think that is definitely something that I expect will happen. But, that we will get better vaccines later on, but it doesn't need to be a problem.
Right. So if there aren't any learning issues, let's go on to the next question. Okay.
So people getting, different types of illness severity. So there are some known risk factors for severe COVID-19, which is the disease, and this is just a list. And for some we have very good evidence from other places. We were very worried about HIV and TB being major risk factors, and they do make it worse on average, but it's not as bad as people feared initially, which is good. And then there are two factors that are really, one is quite speculative, and that is the inoculum, that is sort of the size, the amount of virus that you become infected with. There is weak evidence so far that if it's a little bit, it basically gives your immune system a longer time to respond. But if you get a massive dose of virus, let's say somebody with COVID coughs into your face, and you breathe that in and nobody is wearing a mask, that then, you have a shorter time until the virus really replicates and builds up to huge numbers, and your immune system may not be able to mount an effective response in time. It is speculative, but it has been said that by wearing masks and reducing the amount of virus that people become infected with, one is doing good. And then finally, genetic or hereditary factors, and there's not much I can say about. So I would like to point your attention to this very interesting NICD publication, and that is here from Marianne Davis and Jubal from UCT and the Western Cape government about the excess risk due to HIV in COVID. And they demonstrated, and it's actually a very good presentation, has a good graph that shows the different risk factors and how much they influence the risk of severe disease. And one sees that HIV disease, interestingly, also if treated even, makes it worse, but it's by far not as bad as diabetes, for example. So that's a very good source, and it's also great because it was one of the early papers looking at that, and it really helped. About the genetic predisposition, blood groups, and so on, very difficult to tell. I think the verdict is out. There are some, associations. There is such a profusion of papers and reports, many of which not yet peer-reviewed and properly published, that it's very difficult to keep up on that. There are bigger consortia trying to look at this in a systematic way. I think one will have to learn this. There's still a lot that we don't know. And just a general warning, I think many of these early reports sound very exciting, but they need to be taken with a pinch of salt and very carefully put into context as being what they are. They may offer interesting leads, but I would not take this as for granted in any way. And definitely not as apparently some people are doing so saying, oh, your blood group is so and so, so your risk of getting it is very low. I mean, that is definitely a very dangerous and unethical way of using such very early and unsecure information. I'm sorry about this. I know I didn't really want it to be animated like that. Then, of course, we have learned over the course of the pandemic what the virus does and adjusted clinical management. And the one major improvement was, of course, the high flow nasal oxygen, starting early while people are still very happy, while already hypoxic, to try and prevent them having to be ventilated artificially. And that has been, has had major advantages. Then looking at different drugs to manage, yes, corticosteroids for advanced disease at the stage where it's really the runaway immune response that's causing the damage. That is being accepted as being helpful. Anticoagulants are also used in these severe cases. This remdesivir, about which there was quite some excitement, not quite sure how much good it does. And then, of course, these sad stories, chloroquine. Again, we're coming to certain orange-haired people in Washington, D.C. here, protease inhibitors, and closer to home, Artemisia, the African wormwood in this drug from Madagascar. There is, of course, a lot of natural and man-made products and compounds that influence virus replication if investigated in cell culture. So that on its own means very little. It needs to be non-toxic. The doses that are needed to work against the virus but not poison the cells must be something that can be achieved in vivo, in the human being, with all the other factors that come into play, like our enzymes and so on and so forth, that deal with them, our excretion and so. I'm very appalled about this haphazard way in which these things have been touted and then either propagated or condemned with very little evidence to go by. And I think a lot of damage has been done. So for me, and I think would be my advice, I mean, just taking a step back and taking a deep breath and thinking about it calmly will help. Antiviral drugs, and there are some very good ones available by now against HIV, but also against hepatitis C virus and some herpes viruses. They are invariably at the end of very long research with many other candidates that have never made it. And it starts with basic virology and biology, structural biology research, then a lot of chemistry stuff, and then spending years in animal experimentation and finding the clinical trials before one of maybe 100 or so compounds ever makes it into the clinic. So what is the chance that chloroquine, something which has been around since the 1950s and has been used on hundreds of millions of people to treat malaria before the malaria parasite became resistant against it, what's the chance that it would have a major effect against this virus? It's very tiny. I mean, it's just not realistic that such a compound would by pure chance also happen to affect this new virus in a very specific way. Yes, it may have some moderate effect, but it would never be a wonder drug. I mean, the chance out is just extremely remote. So that, I think, was the first issue. And then, of course, there was the backlash, and there was people, and I think that was even fraudulent, papers published in the Lancet and New England Journal, and those journals also have to account for letting this through and not recognizing the phoniness, the phony character of these papers, that, they're describing major side effects and ill effects of chloroquine. And again, would we expect to now see that this drug kills people in their masses, as they claim, that people who were treated with that had a much higher mortality than others that didn't get it? No, it's not possible, because after so many years, surely medicine knows all the side effects to look out for, and will deal with them. So it's just not credible that something went unrecognized in tens of thousands of people being treated over the years. So both, are exaggerations that are really unscientific and very implausible and can only be explained by ulterior motives or utter disregard for common sense, in fact. Any questions about that? Okay, then let me move on to the viruses, the mutations that are there and their implications. So let me start with the virus that we all know as being very mutation happy.
Sorry, what was the question? I just wanted to read it.
This is now about the mutations of the virus and its implications.
How many mutations have we seen? Sorry, I don't think everyone has seen the questions before.
Oh, I see. Sorry.
They were all submitted to us and then we compiled. So some of us are a bit slow.
Okay, sorry, of course.
I'm sure these guys are much faster than me.
So how fast do viruses mutate and how many mutations have been seen and what are the implications for vaccines and other things? So let me start with HIV. That's the one on the right-hand side here. That is the global diversity of HIV 20 years ago. And you compare that on the left-hand side, on the top, the global influenza, which is also a very variable virus in 1996 across the whole season. And you see how small that is. And just in the middle on the left-hand side, a single individual 6 years after he or she became infected with presumably a single HIV. So only one virus infected that person, then spread and replicated. And within that one person, you have this whole cloud of what we call pseudoviruses. These are all viral variants that emerge starting with one progenitor within 6 years. And on the bottom of the left-hand side, you see the so-called Amsterdam cohort of HIV, about 8 years or so after the cohort became infected. And that is sort of different people, but all infected with presumably one virus, one genetic variant over time, and how much it diversifies. So HIV is extremely diverse. And that is due to its replication cycle and the high activity with which it replicates. And that, of course, poses major problems because the virus can adapt very quickly and becomes resistant to drugs unless the patient is on very good antiretroviral therapy and stays there. So any interruption risks creating resistant virus. And the virus is also very good at evading our immune response. So it's not that the human being doesn't try and mount an immune response against HIV. It's just that the virus mutates away from that. So it's an eternal game of catching up. And we can use that because if we know how fast the virus replicates, we can calculate back the last common ancestor between two different viruses. That allows us to time the emergence of HIV altogether, which is sort of 100 years ago, the arrival of HIV in certain areas, if there was sort of one introduction, but also find out chains of transmission to some degree. That said, after a year or 2 years, if two people became, if one person infected the other, the two viruses you will find even a short while later will no longer be identical, but it can be calculated back at what point these viruses had a common ancestor. So one can try and work out this. Now for SARS, coronaviruses in general are peculiar among RNA viruses in that they do have what we call proofreading. That is an ability of the virus to, as it replicates and makes copies. Oh, I'm sorry, I actually have to apologize for 3 minutes while I just take a delivery downstairs. I'm sorry for that. I could not avoid it. I'll be back in 2 minutes.
No problem, no problem.
Okay. In the meantime,
this is a good time to check in.
Yeah. If there are any words that were mentioned there that weren't clear, perhaps, people could ask and we can try and answer as well.
I see Marcia is unmuted. I don't know if you want to agree. I wonder if we could even put our cameras on for a moment and just see each other. I feel like I'm speaking into the ether. Okay, well, at least Michelle's waving at me.
Yes, and I'm disappearing as well.
I feel so lonely in my space right now.
And Mia, we have Mia as well.
This is a Marcia, did you want to add anything?
I think I must have clicked on it by mistake.
Oh, okay, but it's nice to hear your voice anyway.
Thank you.
Tamara, if you could tell us with the first question about the safety issues about fast tracking the research. So some of the vaccines will can be made available under emergency circumstances and just after phase 3, right? Before they go to phase 3 for licensing. So what are the risks if you start, like distributing a vaccine licensed and gone through phase 4?
I think we're going to have to watch that space very cautiously. I think, I mean, everyone wants it to work, right? So we want it to get there as soon as possible. But the risk of getting a vaccine onto the market before it has some of its safety data and we know more about it is that I think he kind of, I don't know, it wasn't a discussion, but I think Prof. Preiser was telling us about the, the lack of efficacy. So if it's not working, people might themselves, it might impact people's behavior. So if it's not working, but people are now not using their masks, although it looks like no one's using a mask anyway, but, and might not do the physical distance. Oh, I see Prof. Preiser is back. So I guess they
sorry, I'm back. I'm
okay,
back.
good.
And then
the safety issue, as we've seen, where you have adverse events following immunization, as it's called, or vaccine safety issues, it really undermines a program. And I think, Prof, you were mentioning the issue with MMR and autism, how that has had 20 years of repercussions, which is just absolutely appalling when we know that guy was scrapped off the medical roll for fraud. And so we have a real risk here when we see countries wanting to roll something out in a kind of like an old school battle to who's going to be first. Anyway, sorry, I can. I will hand back. Yeah, I don't know if that answers your question though, Mia, or.
But they will know it's safe and it works because they would have conducted phase 3 trials, right? It's just that they would distribute it before phase 4 trials.
Yeah, so phase 3 is what's required, but I'll hand back. Yeah.
Yeah, if I may just comment, I mean, there is sort of the tendency, and I also had that, of course, thinking, new is best because, that's been tested and everything. In fact, pharmacologists will tell you old is best because there are things that you can calculate that by looking at how many people participate in these trials. Even if you vaccinate a few thousand people, there may be rare side effects that you just miss. So, and that is the phase 4 of clinical trials of drugs. That is sort of as it is being used. Sort of worryingly, Russia seems to have skipped phase 3 and is going straight to phase 4. So there will, even if it's been found safe in phase 3 clinical trials, there may still be some surprises in after it's been used on really vast numbers of people. And efficacy, I think that is probably the biggest risk. I do think that a vaccine that would be as efficacious as the flu vaccine, which is about 60% protection, which is not that great, but even that would be better than nothing as long as it is not compensated by people who then abandon other measures. And that, of course, is also the risk. So, I'm not a psychologist at all, but I find it very interesting how everybody is longing for the quick fix. Whether it be chloroquine for treating or vaccine for preventing, sort of is, that the CDC chief has now been fallen out with Trump for saying that actually his mask is the best vaccine because the protection afforded by the mask is as much as would be afforded by a vaccine, which is obviously very unpopular. So I find it very amazing. I'm sure there's many psychologists that will do amazing studies on this, but I've been quite shocked as to how you know, we seem to be at the same level that 100 years ago. But anyway, it's probably human, just human. So coming back to the mutations of the virus. So being an RNA virus, yes, the virus does mutate, but it does so very slowly and little compared to other RNA viruses. So it's a fraction of what you see with HIV. And that is actually good news. So the variants, variant or clade means it's something that does not differ biologically. It's just, you know, there are differences in the sequence, in the genetic sequence, but as far as we can know, it doesn't make a difference on what the virus does, how it behaves, how easily it infects, how severe the disease is, and so on and so forth. So they simply serve as markers for what's called molecular epidemiology. And that, when used together with traditional epidemiology, which is basically counting cases and looking where people became infected and so on, really helps to work it out. And this is a nice study which is being written up for publication as we speak, but it's been published sort of as a pre-version on this Next Strain website. Is the introduction of the coronavirus in the Western Cape, into Cape Town. And in contrast to what people believed, it wasn't really from China, it was via Europe, different parts of Europe. And by looking at the genetic signatures of the viruses in Cape Town, these early viruses in March and in February, we were able to see from which European countries they came. And then, of course, from there, they can be traced back to contact with Wuhan. So we are using this as a marker, but it is happening relatively slowly. So I would imagine that 20 years ago, we would really have struggled. But now we have the so-called next generation sequencing, which allows us to get the whole genome of the virus sequence, which is also the longest of the RNA viruses. So it's not an easy one to work with, and it doesn't have that many mutations. So you really need to do the whole thing to find the few mutations that there are. So it's just in time for the technology. So if we didn't have that technology, we would really struggle, because these things are big and not easy to work with. So this is a very interesting finding. It basically showed that the intensive links between Cape Town and Europe in terms of travel could be Cape Townians traveling for business, probably at that time of the year mostly, but also tourists coming here from up there. That is what brought the virus to the Western Cape. So the genetic mutations found so far, there are some speculations as to differences in biological behavior, and that would then what we would call strain. So the strain sort of tends to be something which is genetically different and behaves differently. Otherwise, it's just a variant. And clades are sort of groups of variants of different strains, groups of variants of the virus. So far, there is no good evidence that they differ in biologically in any major way. So we don't think that has an influence on how the epidemic plays out in a particular place. But they are useful as epidemiological markers for molecular epidemiology. And very importantly, and that links back to the question about the vaccine, we think that the reason why people can become infected with these 4 endemic human coronaviruses often, frequently, regularly, and repeatedly, we don't think this is the same as what we see with influenza viruses. We actually think it is linked to the not so good immune response that these infections cause. And the idea is that if it's a localized infection of the upper respiratory tract, there is very little antigenic stimulus for the immune system to make antibodies and cytotoxic T cells, and thereby people are not left immune, having recovered from the infection and can become infected again. But for influenza viruses, it may also be different. There is the same effect. A mild infection may not leave you immune for a long time, but they, in addition, have this amazing ability to drift that is sort of slow changes in the genetic and antigenic makeup, and occasionally shift. And that means a major change in one of the important surface molecules, which then causes the sporadic pandemic influenza virus infections. So we don't see this in coronaviruses. So we think that, yes, they may adapt and mutate over time, and that may at some stage also mean that viruses emerge against which the vaccine no longer works. But it's not thought to be a process that would happen very quickly from what we know so far. Having said that, of course, we are learning rapidly. But it's not such a mutation-happy virus as some others. But the fear is that, it will also not leave people immune for a long time. So reinfections will still be possible, even though the virus remains essentially unchanged. Any questions about the mutations?
Maybe one from me. So are you saying if the infection stays in the upper respiratory tract, so it doesn't go further, that the body then doesn't produce enough antibodies to get a natural immunity? Am I understanding that correctly?
Exactly. The idea is, if it's a systemic infection, I mean, if a virus goes into the bloodstream and then spreads throughout the body, there will be a massive immune response.
Yeah.
But if it just infects the mucosa, it's the nose and maybe the throat, that there will be much less of an immune response.
Okay.
So that is the idea. It's a very simplistic version. Immunology, I'm not an immunologist for a good reason. It's a highly complex field. And somebody put it very nicely in a serious journal about, how complex it is and how, even seemingly simple matters can be complicated once you look into it from an immunological point of view. It's absolutely amazing, and it's still not totally understood.
Thank you.
Right. I was staying with immunology. So this is now the question: how do T cells and antibodies differ in the impact COVID-19 has on a person and the body's response to the virus? So the immune response to SARS-CoV-2, I mean, the things to keep apart is really there are different components of the immune system. There is the innate or non-specific immunity, and there's the acquired or specific immunity. So the first one is basically, and that is also is linked to certain genetic makeups, something that you inherit from your parents, is something which is there all the time and can kick in at speed and deal with certain types of infections. The acquired immunity is something that is formed by the body in response to being infected or exposed to a certain antigen or pathogen, and this will be specific. And that takes some time, obviously, because it still needs to kick in and roll out. It starts with a somewhat delayed response, which is fairly non-specific, and then it becomes better over time. So over the course of 2 or 3 weeks, the antibodies that one can find are better and better able to react against that pathogen. But there is the time component. And that specific immunity, that acquired immunity, comes in 2 components or compartments: the cellular, that is the T cells, and the humoral, that's Latin for fluid, which is the antibodies. And those 2 are not independent of one another. So to make antibodies, which are the B cells, they need support by T cells. And there are also different T cells that interact with one another. So it's an intricate process. There's quite some good simplified sketches of that on Wikipedia and in other places. But it's a whole network that works together. And the reason why it is so complicated and is a network and it's not just one step is that if it goes wrong, it can be very serious. You have this hyperreaction of the immunity, you have autoimmunity, so it is carefully regulated, and there are numerous feedback loops, positively and negatively, and so on, to try and make it safe and effective. It's something which is evolved over millennia in creatures, in animals, as we know them. Then are, of course, grades of specificity, and that links to the possible cross-reactivity. So, as I mentioned, the earliest acquired immune response even though it is a specific response to a certain pathogen, may not be very specific. So it may be broadly reactive against a whole group of related antigens that look a bit similar, and then it becomes better over time. It doesn't always become 100% specific against a particular virus or pathogen. And that is what some people are claiming they are seeing now, that people who've had previous infections with some of the endemic human coronaviruses may have reactivity against the new coronavirus. And that is really where things go completely to macabre, is what does the immune response mean? So the first question is it a response that indicates immunity? If it does, to what degree? Is it sterilizing immunity? That is what the public would understand. If I'm immune, I can't get this. But it could be modifying immunity. If things go really bad, it could be enhancing. It could even make disease worse if you have antibodies against something related. Or it could help you get not so ill, but still become infected. It may also modify the infectiousness. So maybe somebody with a degree of immunity may become infected, but have very low levels of virus and may not be so infectious. So these are all different things to keep in mind and investigate, of course. And then there is the immune response as a marker of past infection. And that is something different, where the question is not really, is that person immune or not? That is, of course, what people want to know. I mean, everyone wants an antibody test because I want to know, have I had it? And if so, am I safe now? The problem is we may be able to tell whether you've had it, but you may or may not be safe. We can't tell. We still don't know that. And, and then there's, of course, this group of people who are known to have been infected and still don't have a detectable immune response. And then it depends again, are you looking for antibodies, and against what viral antigen? Are you looking for immune cells, the T cells? So there's a lot of variability in here, and it becomes extremely confusing, not least because it is infused with these expectations of basically, first let me confirm that I've had it because I was really very ill and I'm sure it was that, and then am I now safe? And ultimately, an antibody test, and the reason why we normally home in on antibody tests is that's the only ones that can be done at large scale and cheaply. If you look at T cells, it's a very intricate thing. It can be done in very few immunology labs. Needs fresh blood that needs to be processed in a certain way. I mean, talking of thousands of rands per sample per test. Antibody tests, the NHLS is now doing them for, within the very clear confines of what they are licensed for, and that's about 150 rand per test. So you see, it's a huge difference, and those antibody tests are run on big machines and sort of semi-automated. So that is the one thing of which we can process hundreds, if not thousands a day. The T cells and stuff is great for research research projects, but it's not something that we, the country as a whole would not be able to do more than a dozen a day. So that, we're never going to do that for large scale screening. So it'll have to be some type of antibody. And of course, we can improve these antibody tests. We can use different antigens. We can use different ways of looking at them. So, there is still a lot to be done, but at least the first tests have been found to be usable and are now starting to be used for these surveillance programs. The problem being that we know that people with a mild infection may not have antibodies at all. Maybe some people with more severe infections also not quite clear why. And then there's the other problem is that antibodies may not remain detectable for a long time. So whether, we can pick up somebody who's been infected in March and would still have antibodies now, 5 or 6 months later, is a question. Some people may have lost their antibodies again. And that doesn't mean that they have lost everything that their immune system ever learned about this virus. On the contrary, they will probably have an immunological memory, may still be even partially protected, but there is not a simply detectable marker in the blood anymore. And on the opposite, if somebody has antibodies against this virus, and even if we know these are specific antibodies, it does not guarantee that the person is immune. There are people who can become reinfected with the same virus. So, it goes all over the place. But for me, keeping these different aspects and things tested, that are tested and what they stand for, keeping that apart is very important. Otherwise, it becomes very conflagrated and becomes a big mess of stories. And the problem is there are variables all over. Everything is the T cells and the B cells, the humoral immunity against different antigens. So you need to define that, different methods, that may yield very different results, different types of patients. The time course after you had COVID will play a role. If it's too soon, within the first 2 weeks of an infection, you will very likely not yet have antibodies, but they will become positive later on. If it's more than 4 months, maybe, then antibodies may have been there, but by now they are negative again. So you would have to know that. You would have to look at the severity of infection, very mild infection, probably no antibodies, more severe infection, probably antibodies, and then what the antibodies mean. So there's, it's all over the place. It's a lot of difficult and poorly understood aspects to keep in mind here. Does that help? That's the non-immunologist's take on the immune response to COVID.
Are there any questions at this point? Maybe I can just say that I spoke to one of the people involved in running one of the vaccine trials this week, and that they are actually including people that have had previous infection in the vaccine trials because they don't know if the previous infection is in any way protective. So, fills into what some of the issues you've raised. Yeah,
exactly. That's the thing. In a way, it may make it easier if you say we don't have to distinguish between people who've had it or who haven't had it. On the other hand, of course, with 600,000 infections known, you could have quite a few people who would not need to be vaccinated. So you would save on vaccine, but we can't do that because we don't even know whether natural infection leaves you immune or not. So at this stage, we would probably want to vaccinate everybody. The next question is about, sorry?
Yes.
Hi, could you give an example of the cross-reactivity you mentioned? I'm not sure I understand what you mean by that.
Well, the cross-reactivity is, and there was a paper a few weeks ago about people that have not had COVID, having T cells reacting against SARS-CoV-2, the virus, even though they have not had COVID. And the speculation was that these T cells may be the result of previous infections with some of the human endemic coronaviruses. It's purely speculative, and as I mentioned, we've really sorely neglected these endemic coronaviruses over the past decade. So there is not that much we know about it. There are actually quite few studies on that, and no good tools or tests that have been developed. So it is speculation. But some people claim, and of course Professor Mahdi also says that maybe frequent infection with these other coronaviruses is what relatively protected South African population from a high mortality rate from COVID, compared to Italy and so on. But there are many other factors as well. Okay. So, it's very difficult to tell apart. At this stage, it's pure speculation. What we can say is that the antibody tests that have been licensed so far do not seem to have a high rate of false reactive results due to presumably endemic coronavirus infections. So, and that's been done by looking at samples that were obtained before COVID from last year, and those samples were negative. So it basically means, we don't think there is a high risk of false positive results, but of course there will be some degree, like with any test.
Okay, thank you. That helps.
Pleasure. So the infection numbers that are released, so that is sort of from Monday's situation globally, and of course, and you probably all follow the discussions. It really depends on who gets tested and how that is done. And by restricting testing to people at a high risk, people that are symptomatic, for example, or even certain subgroups, as we are doing in the Western Cape to protect the lab services and allow them to process samples quickly. You know, that if you are younger than 55 and have no predisposing risk factors, you won't get tested. You know, then of course you are partially blind. Other countries, even the United States, is still not able to process samples timelessly, and are, you know, in some cases also from what one reads, people are sent home untested and, you know, just on the basis of a presumptive diagnosis told to isolate. And so there, you know, this is basically these numbers have to be taken with an enormous pinch of salt. They differ between different countries depending on their testing policies, and they change over time. And I think this all makes it an extremely complicated type of data to work with. And we have these sort of artificial changes. The same is actually true for death figures. Whether only somebody who is tested maybe and dies, and so is known to be infected and dies, is counted, or somebody with a clinical illness, which might be. So whatever way one looks at it, you know, you will never have perfect figures. And it helps to remember that many of our mortality statistics are actually not, you know, they are calculated in different ways. Most notably, and probably most relevant to COVID, also flu, where one, you know, the annual influenza deaths, about 10,000 on average in a flu season in South Africa. Notable difference this year because we've skipped our flu season, but usually we think it's about 10,000 excess mortality attributable to influenza, which does not mean that these 10,000 people, not even a fraction of them, would have been tested for influenza and found to be positive. So, you know, there are different methods that have evolved over the years. They all come with their pros and cons. Nothing is perfect. Now, if I look at the Western Cape, and I think, you know, I'm really impressed with the provincial government here and the health guys and how they've dealt with this. Also the degree of transparency. And they have different markers, which you all see combined in this slide presented last week. To start from top to bottom, I removed the units on the axis, but it doesn't matter. So the oxygen consumption. Oxygen, of course, is a good indirect marker of COVID because it is the main therapeutic entity for treating patients, and this high flow nasal oxygen needs actually a lot more oxygen than if you intubate patients for artificial ventilation. So it's a good marker. We never, in the Western Cape, needed more than 60% of the theoretical maximum supply, which is also, I think, absolutely amazing. It's great from, you know, if you hear that in some South American countries, there's a black market for oxygen cylinders, and people are frantically trying to put the money together to buy more oxygen to keep their relatives alive, which is terrible. That never happened here. So you look at oxygen demand in the medical sector, and you see how that peaked. You look at admitted cases that were known to be infected. That is the solid blue line. Then people who were admitted for investigation, not all of whom turned out to be actually COVID cases. That's the dotted blue line. Then the red lines are deaths, again, estimated and officially reported deaths, and the test positivity rate. So that is the proportion of tests done for COVID that turned out to be positive. And if you look at all of them and you see that they're all peaked and are then coming down, it's actually good news. Not all of them show the relation to one another as one would expect. You know, they sort of seem to be a bit out of sync. And in fact, the deaths one would expect to be a bit delayed compared to the cases. But you know, that is how it is. You know, I don't think any of these are perfect markers for anything, but taken together and in a trend over time, it becomes very good evidence. And that is why people have called for such data to be published for all provinces. And I think some are doing it, others are not doing it. And one would have to see this for different countries as well to keep things in perspective. Common mistakes that are being made, and you know that, I'm sure, is if you look at the death rate of known cases and say, well, it's very low, and forgetting about the time course. Another thing, of course, is that death risk for death is age. So it depends on the age distribution of cases of COVID. And what European countries are seeing currently is that it is mainly younger people being infected. And therefore, the use of hospitalizations has not yet picked up as it had earlier this year. But that is, of course, not to say that younger population groups, the virus transmission will not also again diffuse out into older groups, into old age homes and other places. And older people then again have a higher risk. And with a 2-week delay or so, you would see hospital admissions going up, and then another 2 weeks later or so, seeing deaths going up. So there, it is extremely complicated to interpret these. And I must say, I feel most comfortable looking at these things. And if you look at our own lab now, this is only Chris, our community service doctor, puts these together regularly. This is just the positivity rate. Now, this, of course, is anything but representative for anything but what we get into the lab. It depends on who sends samples from what type of patient. As I said, it excludes anybody younger than 55 without risk factors who won't even get tested, except, of course, if they are healthcare workers or exposed in a setting need to return. So there are exceptions to that. But if you look at the positivity rate, and if you superimpose the numbers of samples received per day, it would be a similar curve, obviously on a different scale. It gives you confidence that there is a solid trend. And the peaks are, of course, that's linked to workdays and stuff like that. So there are these. This is why normally these curves are averaged out over a few days to make them look a bit smoother. So I don't think there is a perfect marker for this. So we need to look at different markers and know as much as possible about the background. Also remember that in some cases, well, that's hopefully now a thing of the past, people would keep testing people who have been, patients who have been diagnosed to see whether they are now negative and can go back to work and come out of isolation, and nonsense like this. And that would inflate the numbers of tests and deflate the ratio, the rate of positives, unless they were excluded from such analyses, which is in practice very difficult. This is all based on forms that are filled in with typos and transpositions of numbers, and so all of this needs to be interpreted very carefully. I must say, on the whole, I'm quite impressed with the type of data being made available at different levels. So I get them from the NHS, and then I get them also from the provincial government here, which is NHS for the public service, and the private labs for Western Cape patients. But even there, you will find that there are duplications, there are surely omissions, there are surely misattributions. For example, if we get a whole batch of samples from KZN or previously from the Northern Cape to help them out. So it's very difficult to get to the bottom of these data, and that is something about which people can argue till the cows come home. And if you want to, you can, of course, you can rip apart any analyses. But I would say that if you see curves like this, looking at different parameters measured in very different ways, in different chains of notification, and they all seem to coincide, all give the same message, I think that is pretty strong stuff. So, and this is there's basically just the figures added. So, I think we can be confident about the trends. Have to be cognizant that as the lab utilization is now coming down, the criteria for testing will change, and we will see more people tested that are at low risk. which is good because that will allow us to detect early any potential resurgence. But it will also include people who are tested routinely, who are just screened prior to admission to hospital for unrelated causes or prior to having operations done. So there will be a lot more tests, but a lower positivity rate, hopefully. But only then will it allow us to pick up any resurgence of viral transmission. Any questions on that?
Yes. And just to say, I realize we are going a little over time, but you all seem to be staying. So I'm hoping that means you're all still interested. So, but we will understand if anyone drops away.
In fact, it'll have to be me who drops away before they feed my poor son to the lions if I don't pick him up from school. So if I may, I would. In about 5 minutes, I would have to be on my way, if that's okay.
Okay, no, that's good. Perhaps then, because you have more or less answered some of this in the previous session, perhaps we should just open it to any burning questions for the next 5 minutes.
Oh yeah, absolutely. Please, yeah.
Unless there aren't any. Clearly, you've explained very well. Okay, well, maybe carry on for a little bit then, and seeing as no one's jumping up and down.
Okay. So there was the question about the different death rates between different countries, and I think that's important, and particularly when it comes to Africa. So just a few facts about late. So I think the African countries were, in relation to the arrival of SARS-CoV-2 on the continent, were early on with the lockdowns, much earlier than European countries or America. Also, the lockdowns were quite strict here in Africa. And the early cases, which may have done harm because it sort of portrayed it as not being a problem for the majority of people, is that it was a disease of the affluent. So it was the elites, people who were traveling, basically, who brought it into many African countries. And I think the same is true for the Western Cape. I mean, obviously, affluent travelers and Capetonians that returned. And then I think what we saw here in Cape Town is that these early lockdowns worked well for the middle classes and above. They only suffered because they didn't have ready access to their staff. But of course, it neglected the social reality of the majority of people. And this is why, despite the lockdown in the Western Cape, we saw an ongoing spread of the infection. So it didn't have the expected effect. And actually, while definitely not intended like that, it may not have been the worst thing altogether, in that it delayed the further spread, allowed the health system to respond, and maybe allowed us to do what is counterintuitive, that is opening up successively and slowly, without without being punished by, like many other countries were, with a massive resurgence. So maybe, in the end, it all worked out actually quite well, I wonder. As regards Africa as a whole, there is definitely under-ascertainment. You are aware that in MRCs, there is twice as many cases, or 3 times as many cases as have been known to have died from COVID. There are, the excess mortality over that time, some of which may have had COVID, others may have died due to lack of medical care due to the lockdown or other causes, very difficult to keep apart. And then, of course, this speculation, did our, the higher rates of exposure to infectious agents in Africa, particularly among the poor, did that contribute to making people less susceptible to infection, or at least to severe disease? So as regards not now the infection, but actually the disease and disease severity, clearly the average African population is younger than in the other badly infected countries, and that helps. And one can calculate how much fewer severe cases and deaths one would have seen just because of the younger average age of Africans. I'm not so sure about the prevalence of risk factors like diabetes, obesity, which is quite prevalent. It may be less prevalent than in some of the other countries. I don't know enough about that to be able to say. But on the other hand, I would also claim that the people with diabetes are less likely and hypertension and so on, less likely to be well managed in Africa than in other parts of the world. Again, I have no data on that, but I know from the Western Cape that they found that COVID, they said it flushes out diabetes. It revealed patients who had been diagnosed and had not been on treatment, and patients who had not been diagnosed but were diabetic. So I'm not sure about that, in how far that was a protection for Africa. Surely that HIV and TB weren't quite as much drivers of excess risk of severe disease and death came to our help. Also, the underestimation of deaths is another issue. Depends on how it's counted, and that is also a problem that's seen universally in all countries, but of course with very different details between different places. I don't think there is any genetic explanation for a lower mortality rate. If you look at the United States, it's the ethnic minorities, including Black people of African origin, that have much higher rates of severe disease and death than the majority. So I don't think there is sort of, that doesn't look like there's sort of a genetic difference that would explain these differences. There is, of course, also as regards severe disease, it may be partial immunity that doesn't render you immune, but partially protected. People may be relatively protected due to these previous infections, maybe also BCG vaccination. That's another purely speculative thing, whether having had BCG vaccination, which was abandoned in many of the industrialized countries, but is still done here routinely, whether that is protective. Helps, that is the warmer temperatures. Not sure, I can't attest to that here in Cape Town over the past months. I didn't have warmer temperatures than elsewhere. Not sure that can be confirmed. I think that was a spurious thing which does not take account of South America, Brazil, the Amazon being badly affected. So I don't think there is that much difference in the virus's transmissibility between different weather conditions. So I think it's probably it's going to be a combination of those. That is what I wanted to say, and then there's just some general points. But I could go on forever. But actually, if I may just give a hint, there is this brilliant book which I've had for several years, and I once listened to talk by the author Howard Phillips, a retired historian from UCT, who recently did a few months ago did a webinar with Jacana, the publishers, about this book, and it's still available if you look it up there. Absolutely amazing that this is many of these aspects and things that is anything but new. It's been seen just like this with previous pandemics. Absolutely amazing. The reaction of humans, the things that go wrong, the things that go right. It's all been there before. It's just it takes so long in between pandemics that people tend to forget. The generation, each generation has to discover it for themselves, but it's patterns playing out over and over again. I think I would leave it at that.
Thank you.
Go and rescue my child from the lines.
Please do. And that'll be great. If Tamara and I can maybe field any last burning questions, if there are any. But thank you so much, Wolfgang. And we will come back to you if there's something that we are stuck with.
Please do. Wonderful. Thank you so much indeed.
Thank you so much for your participation. It's really appreciated.
Bye-bye.
Thank you so much.
Okay. I just want to have last
Bye.
chats. Oh, okay. We just lost Joan, and then Tamara has put up a link to that Howard Phillips piece. Tamara, anything else you want to say? Does anyone have a question that they really felt they didn't get a chance to ask, or was there a word that was used that was not explained well, or anything like that?
No, it was.
Okay, I'm not seeing any.
I work in the space, and I still found it is very technical. So.
But I mean, maybe feel free.
It's a pity we don't have a chance to meet.
Yes. If anything comes up when you
Mara, it's Mia.
Hi, Mia. Yes.
Great. Sorry. Go ahead, Mia.
I'm not sure that you're the right person for the question, but I'm going to ask it in any case, because it might be drug companies that need to. So they pre-ordering vaccines that we don't yet know works, right? And they starting to manufacture these vaccines so that if it turns out to work, there are enough of them. So who covers the costs? If these vaccines, if you have made billions of doses of a certain vaccine and it turns out to be unsafe or not working, who covers those costs?
That will have to be borne by the companies.
Sure.
So, I mean, I'm within the national department where we're starting to develop a process to review the evidence on the vaccines. The evidence will need to be reviewed and approved by a number of groups. So looking at the evidence, but also looking at feasibility and cost and equity issues and access and deciding who will be the first to get it. So if companies are making it, I presume it's going to be borne by those companies, or there is this big COVAX initiative, and I'm not across how that all works. But if you have other questions, I can explore and find out. But at the moment, there's definitely there are vaccines with promise, showing promise. Happy to hear about, but they're nowhere near being approved. And so there's a very close working with the South African Regulatory Authority, our kind of equivalent of the FDA, the SAPRA, and the National COVID Guideline Group, and the group that I'm on, which is the Essential Medicine Group, because obviously vaccines falls under the essential medicines and under the national tender process. So all of these groups are actually all linked in to try and coordinate so that as soon as we see that there's something worth having, that there'll be a process. So there's thinking around the economics of it. There's also thinking about supply chain, but there's nothing concrete more than that.
Okay, thank you.
But I know it sounds like you have also issues about, questions around the production side and preparation side, but yeah, maybe we can keep in touch around those things.
I also have a question. Yes, it's Marcia.
Thanks.
So I have a question regarding the of the vaccine, right? So Oxfam has raised concern that rich countries are actually purchasing a huge amount of the resources for the manufacturing of the vaccines. So I just want to know, like, where does South Africa fall within that? Are we having enough resources for that, or are we also going to be left behind in terms of what is available when it comes to the manufacturing of the vaccine?
So thanks, Marcia. I think it's a great question, and I'm not immersed enough in the vaccines field, except to know that South Africa is one of the signatories to this COVAX process to make sure don't take all the stocks and poor covers. I guess we will see, but I think your concerns are valid and real, and it's a space that we need to watch closely in terms of so many things, equity and corruption. And I know, I'll say that's about all I can say. I know there's a group, I don't know if you're all familiar with Open Secrets, where they look at economic crimes and related issues around kind of financial mismanagement. And they've been looking at issues around access and corruption and issues, but they might also be a useful resource to check if they're finding anything on this. But that's a bit out of my field.
Anything else that's
but I think
desperate?
we have, yeah,
We've probably.
I think we way over time. I think we didn't have a chance to meet and greet, and also to hear more about what kind of questions and stories you're busy with, and how we could be of use. We found someone who's very technical to come on board, and I hope he's managed to answer many of your questions. He certainly highlighted quite a few things for me that I've learned a lot. But I think we should close down for now. And I just thank Mia and colleagues and Joan and others for enabling this, and we're grateful for the engagement.
Thank you very much for your time, Tamara. And so, yeah.
Thank you. And yeah,
yours.
Please feel free if you do have additional questions to send them to us. Okay. Thanks, everybody.